So, welcome everybody. I think this is a timely webinar because I think there's a lot of progress in the area. There are massive textbooks being written about the use of pulse wave velocity in the clinic. I think it's ripe for convincing clinicians to use the technology. And I think we have a lot of evidence to show that that it is useful. One of the problems is that it takes some time in the normal clinics, and doctors don't seem to have too much time other than just taking blood pressure. So, but I think congratulations to Jeong Bae for motivating this paper. It's an excellent paper, and I think it's very informative, and it's and everybody's put in a lot of effort to try to make a clear case for the use of pulse wave velocity in the clinic, and I think and especially in Asia, which has most of the world's population. So with that, I'd like to carry on with the webinar. Jeong Bae, go ahead.
Okay, I will just give you some of the information why we prepared this paper, the expert consensus on the clinical use of pulse wave velocity in Asia. So, sorry. Ines, can you help me this? I can't go back. Okay. At this time, we want to have 5 sections to discuss the introduction and the pulse wave velocity is really methodologically different, and how to standardize the pulse wave velocity measurement, and how to increase clinical use PW measurements, what is perspective in clinical and research aspects. We have 5 speakers, and we have many discussions on all the authors of this paper. So Ines, help me again to affect the next one. And I've just introduction, which is my introduction. The fact is that with the increasing age, arteries become stiffened, arteriosclerosis or arterial stiffness. But this increases linearly with the risk of cardiovascular disease. The aging is particularly a big risk in Asian countries. And the pulse wave velocity is a real reliable tool to predict cardiovascular disease. It's already a well accepted idea. But what is the reality is that there are still large hurdles in applying the concept of pulse wave velocity in clinical use. Many are accepted, but clinical use is much less than our expectation. And the more than the guideline pay minimal attention to the clinical use of PWD. Maybe the hypertension is very closely related with the PWD measurement. But however, even the hypertension guideline has a very reluctant to accept the idea in clinical practice. So one of them is that there is no standard method, or the methodologically different idea is put into this idea. So many consensus on the standard method for measuring the PWD. So I want to discuss why it happens and how we can improve the clinical use in the PWD measurement in the clinic. So this is my introduction. So Alberto, can you continue about the methodology difference?
Sure. So in the paper, we addressed the various methodologies that are used for pulse wave velocity. Not all of them are totally applicable. Most are, and they all have particular form of information. But in general, they try to give an information on the pulse wave velocity as a metric of arterial stiffness. So we've got brachial ankle pulse wave velocity. cardio-ankle vascular index, carotid femoral pulse wave velocity, estimated pulse wave velocity, and then other regional and local pulse wave velocities. So, okay, I'm trying to advance here. Here we go. So the brachial ankle pulse wave velocity is especially adapted to the Asian communities in relation to the availability of the sites for detecting the arterial pulse. And so this technology is fantastically well developed and well analyzed. There's a lot of papers, a lot of studies, and I think our Japanese colleagues have done a fantastic job in getting this technique out. Of course, it's quite particular because, as we see, it uses cuffs, so that the waveform is detected by the cuff. So it's usually it's probably a damped waveform, and so some signal processing has to be made to actually detect the foot properly. But even so, it has a lot of merit because it's non-invasive. Obviously, all these things are non-invasive, but non-intrusive, essentially. So it's like measuring blood pressure, and also with the cuffs, blood pressure is measured at the same time, which is an interesting situation because then one could correct for blood pressure. The specifics are that in fact it includes muscular arteries, and so the pulse travels through the aorta and through the muscular arteries, and so this becomes a little bit of a problem with interventions. If there are interventions that affect smooth muscle tone, it may affect again the functional stiffness that then could be confused a little bit with the structural stiffness, as we say in the paper. But I think under steady state, it has a lot of potential and a lot of data could be obtained. And I think it's well developed. We can see that the distances are measured in terms of height. So overall, there are a number of approximations, but these approximations have been shown to be quite good in delivering useful data, especially in populations. In individuals, especially if one does a follow-up in individual, these are constant. So they don't form any, they don't create any problem, these assumptions in the individual measurement. And as I said, the important part of any measurement of pulse wave velocity is the blood pressure. So now the device, the CAVI device accounts for that, which is a really big advantage. So in this case, it is obtained by measuring pulse wave velocity measuring the pulse in two places, in the arm, in the leg, obtaining the transit time, obtaining a pulse wave velocity, from which this index is determined, which is a pressure independent stiffness index. So it becomes an interesting idea to correct for blood pressure in the individual. So before, right, with all these other measurements, if there are pressure changes, we can correct for pressure changes in the group. In this case, it's corrected for in the individual. However, there is a reference pressure which is important, and that's the diastolic pressure. So this is also an index which is well developed, well studied, well sort of thought out, and it is based on robust physiology. The conventional gold standard of pulse wave velocity is the carotid femoral. That's because the carotid pulse is easily accessible, and so is the femoral, although it is intrusive. So the two caveats there are that the carotid bifurcation here is after the arch, which means that most of a large part of the aortic compliance is in the arch, which is not included in this measurement. And also the iliac segment is a muscular segment, not very long, but it could influence, as I said, situations when there are interventions that affect smooth muscle tone. The object is to get the aortic trunk as best as possible. The only way to do that properly is with MRI, which is not an applicable method because it's very expensive, and it's of course it's good for research, but it doesn't apply in the clinical situation in terms of clinical measurement. Now, with all of these measurements of pulse wave velocity, there's a lot of data, and the data has been used as a data-driven model to estimate pulse wave velocity. And we know that the two most important parameters are age and blood pressure. And in this case, the reference value work, which is we produce data to obtain regression estimates for estimation of pulse wave velocity. So this is fine. Now, the stumbling block here, when we read papers that use this method and then perform regression models with age and blood pressure, you get what you put in. Now, these regression models are usually linear, so they probably do not take into account the higher order values of the squared values or the covariates. So what is intriguing is that the estimated value of pulse wave velocity has been shown to have some predictive value above the values of blood pressure and age. Now, maybe it's got to do simply with the higher order terms here that are usually, maybe they're not taken into account with these models. So although it's attractive, if we've got age and blood pressure, we can then combine these two and obtain a stiffness index, which is useful. When one performs statistical modeling, then one has to be careful that you actually get what you put in. So you will always get a correlation with age, you will always get a correlation with blood pressure. Now, and the added value, as I said, one has to be careful that one is just possibly demonstrating the nonlinear terms in the regression. So the regional values are essentially values in the arm, in the leg, the heart to brachium, which is interesting because again it includes the aorta, finger to toe, radial to digital. Now these are interesting measurements because they provide information on stiffness gradient, and so there is a body of work that is showing that when this stiffness gradient changes, there are situations of impedance matching, which is an interesting problem. So it is advisable to be aware of these particular measurements. And so there are also measurements that are performed at the local level, which are based on pulse wave analysis of single site measurements. And so these involve wave separation. Some look good, some look not so good in terms of correlations, but you know there are potential uses, again taking into account what one is looking at. If one is looking at interventional changes or steady or population changes. So these are the various measurements that could be used. Now, in terms of values, I think we've got the table in the paper which shows the breakdown of the values. Of course, the values are different. The brachial ankle pulse wave velocity with the carotid femoral are different, and so the cutoff are different. Cutoff values are different, but in terms of relative changes, they show a comparison. And so it is of interest to actually compare these indices. And so now there's probably sufficient information for justification for regulatory agencies, reimbursement committees, and so on to say, look, we've got enough data here to make a convincing case to use these indices. Thanks.
So it is now open to the discussion.
So who's leading the discussion?
You can lead, and maybe probably you better than me.
So I mean, the discussion on what? I mean, do we still need more data that we have to convince people to measure these things, or what? or is there sufficient? All we need to do is to be proactive, to mobilize these measurements. How much more data do we need to say that these measurements are useful? I think one thing which I think is important to consider is that, in people's minds, somehow a blood pressure difference of 130 to 140, it has some meaning. Does a pulse wave velocity of 9 or 10 have the same meaning in people's minds? And this is probably the simple stumbling block. Do clinicians or people in the field understand that there might be, if the cutoff is 10 meters a second and a patient has got 11 meters, what's the problem? Because now we know if your blood pressure is 130 compared to 145, there's a problem. You are called hypertensive. What happens with the pulse wave velocity? If it's pressure dependent, therefore the question is, do we just need to measure blood pressure? And that's all. Or is there increasing inflammation? And the CAVI index has shown that there is additional information. We know that there's additional information. We know that there's prognostic evidence of people with a similar blood pressure and different pulse wave velocities have got different risk factors. We know that. What more do we need? And this is the question that comes up.
Alberto, we can also think in the other way around. If we can measure pulse velocity, why we measure blood pressure? Because recently in China they did a study, and they showed a very clear-cut blood pressure reduction in clinic blood pressure, in clinic measurement. But then they showed a blood pressure increase in home blood pressure. Then they look at the pulse velocity. Pulse velocity actually increased. So you see, pulse velocity is very accurate, and it consists with a home blood pressure measurement. And clinic blood pressure is actually not accurately measured or even not really measured. So that's the problem. So you see in a trial, you see a very big blood pressure reduction in clinic blood pressure, but no reduction or even increase in home blood pressure. Then you see increase in pulse velocity. So the pulse velocity is more accurate. Or then you can.
I think if one looks at the idea again of precision medicine of individual patients, I mean, if one does risk factor calculations, if these things can modify risk, it's useful. You have a risk calculation, you input a value of pulse wave velocity, you modify the risk. Okay, that's information. That's useful. But that is useful. And so what more does one need? I just know, maybe the clinical people can advise us. What more do we need to be convincing? Where are the problems?
I think we have to change the idea, because many people are trying to some connection between the pulse wave velocity and blood pressure. I don't think it's blood pressure is not all reflect the pulse wave velocity, because the arterial property is mainly determined by hemodynamic changes, but also very closely connected with the humoral factors like intra-extracellular changes like angiotensin II endothelialism. One of key the influence of the artery mechanics. So even the guidelines say maybe the people will be made some good tool to add the risk of cardiovascular disease in hypertensive patients, but I think it's wrong. The artery is independent, or even though it is very closely related to high blood pressure, but artery changes, not blood pressure changes. So we have to think differently. So maybe
but I think people understand high cholesterol because it's got to do with blockages of arteries. When one looks at stiffness of arteries, I don't think it's understood in the same way. It's not understood in the same way as a risk. We understand it because we do studies and we perform calculations. But in the clinic, I mean, how do we convince clinicians overall to say that it's important to measure?
Yes, Albert, I have one comment.
Yeah.
For each method to measure the arterial stiffness has some limitation and also some benefit.
Yeah.
It might be different in each equipment. Even though the repeated measurement of the pulse wave velocity might be important, because in the clinical setting, we have to prevent the progression of the arterial stiffness. As the current state, it is not clear whether the prevention of the progression of the arterial stiffness is very effective to prevent the cardiovascular outcomes. So we need some studies, the longitudinal follow-up and its change related to the cardiovascular outcomes. How do you think about that?
Well, I think it's true. I think it's true. I think the other problem also is that the way to prevent arterial stiffness is to prevent aging or lower blood pressure. You know, you can't prevent aging, but you can lower blood pressure. So if you lower blood pressure, does that mean you also reduce arterial? And if you have these other factors, and we're hoping that Dr. Spronck is going to provide some really important information on the aorta, on the active function of the aorta, to probably, you know, nail some of these concepts to say that there is in fact some active function of the aorta that could be addressed by measuring pulse wave velocity. So, yes, I think Dr. Miyama, I think it's true. We need more studies, but I think now we are at a state of being able to collect data that could be put up as in the cloud. It could be collected in association with blood pressure data to be able to perform these risk analyses for sure. But I think that there's a blockage here in terms of people trying to figure out what does it mean to measure pulse wave velocity in the clinic. This is the impression I get.
And perhaps
Avolio.
there's also, sorry.
Sorry, I have a question on the estimated pulse wave velocity. I don't think it's a kind of a measurement. So what's your view on this so-called estimated pulse velocity, Albert?
So I think the estimation is like a combined effect of age and blood pressure. So my view is very specific. I think it can be used as an index, but you can't perform risk calculations based on age because you get out what you put in, right? So and you can show that there is some correlation between the calculated and the measured, because we know that there is a strong correlation with age and blood pressure. Now, the question is, we know that a measured pulse wave velocity can give you additional information beyond blood pressure. So you can have, again, somebody with the same age and the same blood pressure will have different pulse wave velocities. With the estimated one, somebody with the same age and the same blood pressure will always have the same pulse wave velocity. And that's the problem. So where is that percentage of extra information? Now, some studies that show this extra information with the estimated pulse velocity, I think what they're doing is showing the nonlinear components of that calculation. It's because the regressions are linear. They're showing the nonlinear part, you know, age squared, so it's that one. Now, well, if you put that into the equation, you always get the same thing. So as a combined index of age and blood pressure, it's fine. As a useful tool to actually get extra information on arterial stiffness beyond blood pressure, I think it's limited.
Yeah, that I fully agree with Albert here. That indeed, I mean, you beautifully put it on the slide. I mean, it is just a regression equation, so that's all the info that goes in there is age and pressure. So that's also what you're gonna get out. So I was thinking about another potential way where pulse wave velocity helps us. So blood pressure is really an instantaneous measurement. It fluctuates very heavily, depends on your stress level, etc. Whereas stiffness is sort of an integrator of this. I mean, if you're living an unhealthy lifestyle for a long time and have an increased blood pressure, then that in the end will cause your arteries to remodel and to stiffen. So perhaps arteries are sort of tell us more of the history also of the blood pressure, that what has been the blood pressure, and not just a moment. Especially if you correct the stiffness for blood pressure at the time of measurement using, for example, CAVI. And about CAVI, so Albert mentioned very nicely that carotid femoral pulse wave velocity is limited because you miss the first part of the aorta, where there's a lot of buffering capacity, a lot of wind vessel function. So CAVI actually does take that part into account because it starts at the heart using the heart sound. So CAVI potentially has a big advantage there, because there it actually does allow you to look at the ascending in addition to, for example, MRI techniques. So I think there's potentially a big advantage there as well.
Dr. Spronck, I have a small question to you.
Yeah?
Yes, so how about the combination of the heart ankle pulse wave velocity with CAVI, or the difference of the heart ankle pulse wave velocity and CAVI, which is more important issues? Do you have any comment about that?
So CAVI is basically calculated from the heart ankle pulse wave velocity, right? So CAVI takes the heart ankle, measures the heart ankle pulse wave velocity, and then corrects it using an exponential function to make it blood pressure independent. At least a lot less blood pressure dependent than the regular pulse wave velocity. So I think, and this basically relates to Albert's point about estimated pulse wave velocity. I think correcting for pressure on an individual basis is of crucial importance if you want to make the point that stiffness has additional benefit on top of blood pressure. Because, I mean, as we all know, pulse wave velocity fluctuates heavily with pressure. So if you don't do that, then, I mean, pulse wave velocity may be a nice risk marker, but to a big extent, that is just due to its dependency on blood pressure. Whereas CAVI, in addition to that, shows prognostic evidence. And so I think actually CAVI may be the way forward for us to make our point, basically to say, look, if we correct away blood pressure, and we can discuss about how best to do that, but then what's left is still predictive. And that's a very important point, because that's actually telling us, look, this is more than just pressure. So I think, yeah. So I think CAVI is a great idea.
Bart, can I add something about this?
Yeah.
I had a comment about this, because you are saying that pulse wave velocity is pressure dependent and so has no added prognostic value on top of blood pressure, but this is not what the epidemiological studies showed. So it's true that these parameters are blood pressure dependent, but it does not mean that they don't have additional predictive value on top of blood pressure.
Well,
this is evidence that we have already. We don't need to change idea.
No, I think we're
you are
mistaking
talking about the
here.
pathophysiology, I'm right, but when we are talking about clinical practice, then we have to look at the epidemiological data we have. Of course, I'm not saying that CAVI is not good, but you cannot say that the other measures are not good.
No, absolutely not. And of course, there is. I mean, we all agree that there is something in pulse wave velocity, but there's also blood pressure information in pulse wave velocity. And the question is, if you don't account for that, then by definition, you will find pulse wave velocity to be predictive based on the blood pressure. But of course, there is more in it than just blood pressure. Absolutely, and that's what you're referring to. And yeah, no, of course there is. If you correct for blood pressure, either statistically, as in those epidemiological studies, or using Gavi, there's still something left. No, of course, absolutely. So if I wasn't clear about that, I'm sorry, but no, for sure, pulse wave velocity itself is still useful.
Okay.
You know, I'm looking at the time. Maybe we should advance to the next session. But I think the point is that, you know, I'm just wondering how much more information do we need to convince people to measure arterial stiffness? This is the question at the moment.
Yeah. So
I haven't quite answered it.
Yeah. So if I may, can I ask Rosa Maria to comment on that, because she has as a clinician also has very specific thoughts on what is missing.
But in my view, still, we produced a lot of evidence about the prognostic role, the prognostic significance of all these arterial stiffness measures. What is missing is how to include those measurements in clinical algorithms. So we need randomized clinical trials to test the evidence of new biomarkers. And because they have to guide the therapy, they have to change clinical management to be useful for patients. And this, unfortunately, has not been done yet. This is what has been done for calcium score. We have calcium scoring guidelines because we have studies where treating patients differently based on the results of calcium score. And this is what is missing for pulse wave velocity. We need those trials. And we need cost effectiveness analysis demonstrating that these preventive strategies are more effective than using the simple calculation of risk by classical algorithms. When we have these two things, then of course clinician will use it.
Okay, move to next one.
Okay, thank you very much. Thanks, Albert, for a really nice lead up to what I'm gonna speak about, which is the standardization of the measurement of pulse wave velocity. But before we get to that, I want to take you one step back, perhaps, and that is, I mean, before we use a device in the clinic, we want to actually validate the device and make sure that the device works appropriately and actually measures something. And how do we do that? How do we measure different devices? For example, a device that measures carotid femoral pulse wave velocity versus brachial ankle pulse wave velocity. They are clearly different devices, so we will also need different references. So the last device validation guidelines date from 2010, as shown here. However, brachial ankle pulse wave velocity at that point wasn't that much studied, that much reported. So we do really need an update on this document. And I'm happy to say that we're very near completion of this update, which I'm leading together also with Rosa Maria. And for this paper in Pulse that we are all part of, we sort of posed three key issues that we think are very important, and that we will indeed address in these new guidelines. So the first issue here is, can we directly compare segments? Can we compare for example, carotid femoral pulse wave velocity to a brachial ankle pulse wave velocity? Well, as you probably know, and as Alberto already was showing in the table, brachial ankle pulse wave velocity is systematically higher than carotid femoral pulse wave velocity. This also makes sense because the arteries towards periphery are more stiff, and there is a higher pulse wave velocity. And since brachial ankle pulse wave velocity includes more of these more distal arteries, this makes perfect sense. But it also means that we cannot directly compare the two values. One cannot use the same cutoff, for example. So then the question arises, okay, how do we solve that? Well, there's different approaches to this. So one of them would be to use percentiles. So do a reference value study for each of the devices, ideally in the same population, and then use percentiles, and based on these percentiles, use cutoffs. Another way, which basically comes down to a similar thing, is to calculate a person's vascular age. So which means you look at the reference values and you see, okay, to what age does this measurement correspond? And then instead of calling it a pulse velocity in meters per second, call it the vascular age in years. And then if one wants, one can compare it to the chronological age. But of course, what we can also try is to use a conversion formula. However, as we will see in, I think, issue number 3, that's not as trivial as it may seem. So these are some potential solutions to this comparison issue. The next issue is, okay, what do you validate against? So for carotid femoral pulse wave velocity, historically and traditionally, this was simple, because one could actually measure the so-called true pulse wave velocity invasively using a catheter, either 1 or 2 catheters, and then compare the surface measurement to this invasive measurement. However, clearly for brachial ankle, this is an issue, especially for the ankle. There will not be a catheter there, so an invasive validation procedure is basically impossible. So what we've proposed in the updated guidelines that are coming up is to not do it against an invasive measurement, but rather to validate against existing brachial ankle devices that have proven prognostic relevance. So have proven to predict clinical outcome, basically. But in general, of course, one needs to validate against the same arterial bed, and to further refine this, there's different ways of calculating the transit distance, and also here one needs to make sure that if a device claims to, for example, a carotid femoral device claims to measure the stiffness using the 80% rule, one wants to validate it against the 80% rule. Whereas if a device claims to give a subtracted distance-based pulse wave velocity measurement, that's what one needs to validate against, because it's known that these values are simply different. So this must be taken into account. And then finally, okay, how do these different measurements compare in terms of risk prediction? And we've Alberto has shown, and I think next speakers will tell us about that all of these metrics are predictive. So brachial ankle and carotid femoral, but also CAVI. But the question is, which one is best? One may ask. And so there's surprisingly little studies that actually, in the same patients, measure different pulse wave velocities and compare the predictive power of these. So as far as I'm aware, there's no direct one for brachial ankle versus carotid femoral pulse wave velocity. There is a story from 2005 already from Panier et al., where they compared different pulse wave velocity measures, and I very briefly summarized here. So they compared carotid femoral, carotid radial, and femoral tibial pulse wave velocities. So unfortunately, not brachial ankle. And they actually saw that only the carotid femoral in their comparison was predictive for a disease progression. However, this is a very specific population, of course, and this is not in general generalizable to everybody. So in short, I mean, what I think would be really helpful is direct comparison studies between those different markers to answer the question, because I mean, I can imagine. I mean, I am not a clinician, but if I would be asking, okay, what should I measure? Should I measure carotid femoral, or brachial ankle, or CAVI, or hard ankle pulse wave velocity, or one of the other ones? And individually, they've all shown to work. So I mean, to be clear, it's best to measure anything rather than nothing. But to take it a step forward and ask, okay, if we want to say in 50 years, what should be the gold standard? To my knowledge, we don't have robust evidence proving this. So I think there is also, in addition to what Rosa Maria was mentioning, a room for improvement there. So that concludes my part of the presentation, and I hope to have some discussion on this either now or at the end with more discussions.
I have one comment. Okay.
Yeah.
Can you? Okay. But you demonstrated data of the end-stage renal disease, indicating that prognostic value of aortic stiffness is good, but leg stiffness was poor. But you know, as you know, there are in our J-bubble study, brachial ankle pulse velocity demonstrated a very nice prognostic value of the cardiovascular events. So what we can say now, you know, the in vivo outmuscular stiffness, is not equal a simple summation of the aortic pulse velocity and leg pulse velocity. That's the answer. So we must consider, that brachial ankle pulse velocity is the individual combination of aortic pulse velocity and leg pulse velocity.
Yeah.
So the reason, I don't know the reason, but this is a very important issue we should be researched in the future.
Yeah. No, thanks for clarifying. No, absolutely. I'm not saying that the other stiffness metrics do not work for end-stage renal disease. Not at all. This is the only study that I'm aware of that compared different metrics head-to-head in the same population, and there apparently carotid femoral was a bit stronger. But no, I absolutely agree. So and I also thanks for highlighting that indeed it's not a simple addition of two pulse wave velocities to get to the brachial ankle pulse wave velocity. There's indeed way more to it.
But I think it's also a question of sensitivities. The change, like for example, with age in the arm and in the leg is much less. It's about half than that in the aorta. So it's less sensitive. Those regions have got there's less sensitive to structural changes.
Yeah, absolutely.
But they might be more sensitive to blood pressure. I don't know, but again, it's that sensitivity, the pressure sensitivity that is the basis for some of these wearable devices to measure blood pressure. Obviously, if one uses transit time in the arm, it's that one. But if one were to look at the aorta, it might be more. So I don't know, but I think it's so when one looks at the risk predictions and so on, it's about that. There's lower sensitivity in these beds.
Yeah.
Well, what about the reproducibility? Because usually copy and the BAPW is much easy to measure the PW. But in case carotid femoral, we have to tonometer on pressure. There's maybe operator dependent. That's why in Korea and Japan, many people are very used to use the BAPW and copy.
Yeah, thanks for that point. So carotid femoral, indeed, I think one of a big issue of carotid femoral pulse velocity is actually the distance measurement, which turns out to be quite tricky, and there's still discussions and debates about whether one should use the direct distance from carotid to femoral multiplied by 80%, or use the subtracted distance using the notch. But in my opinion, actually, the concept of brachial ankle using a height formula is quite clever, and although maybe strictly anatomically speaking, you're making some error between people with I don't know, longer arms or longer legs, but in the end, what you do get is a lot of noise reduction because there's no measurement errors anymore, and so I think that actually is likely one of the key advantages of brachial ankle pulse wave velocity, and I would certainly be in favor for also simplifying the distance measurement of carotid femoral as much as possible, and perhaps even also there just use a height formula, because I think that's we're unnecessarily trying to be as anatomically correct as possible, whereas perhaps we're not doing ourselves a favor there.
But
I have
Bart,
a comment.
indeed, we have one validated formula for calculating distance for height for carotid femoral pulse wave velocity. It's true that
Yeah.
it's not widely used, but indeed, what I think what we have in terms of validation now, it's interesting, but it would be easy to have more validation studies on this formula to understand if it can simplify the use in clinical practice of the carotid femoral pulse velocity.
Yeah,
I think, Rosa, I think that formula has heart rate in it, which is quite interesting. A distance depending on heart rate. It's a little bit unusual. This is the data-driven formulas we're talking about.
Yeah. So the issue here is this is again us physiologists talking, whereas I mean, if you look at it statistically or epidemiologically, I mean, there was apparently a statistical reason to have it in.
Yeah.
So, but that's always I think in general a bit of the balance that we're trying to strike here between, you know, doing everything as correct as possible versus having something that is easy and robust in practice. So it's a really interesting one. But I agree.
It's true when you put a lot of variables like this in a formula for estimating distance. I think that a work that should be done is to try to debulk a little bit, no? Try to leave one variable and see if the predicted values changes significantly or not. So probably this is work to be done. This is a research project for the future, I would say.
So because of time, we have to move next one, Alberto.
So, Dr. Kario?
Yes.
This is
Okay.
to increase, and this is important because to increase the clinical use. So we should hear now some important reasons why we need to increase the clinical use of pulse wave velocity estimation.
Thank you.
Go ahead,
So,
Dr. Kario.
As discussion a lot here, we have already a lot of information of the epidemiological study, the cross-sectional, also longitudinal study, but it's still on the way to use the PWV, pulse wave velocity, to use in the clinical practice, because we don't know how to reduce the PWV independently of blood pressure, and also degree of reduction could directly lead to the reduction of cardiovascular events. We don't know this clear evidence. So that's why the doctors could not use the clinical indicator for the clinical practice so much. So that's why we need to show the clear strategy to reduce vascular stiffness, and also we have to have the clear evidence. The reduction should lead to the reduction of cardiovascular events, like the blood pressure reduction. So, but the problem is the reduction of the PWV is not independent of the reduction of the blood pressure per se. So, final strategy should be get into the guidelines. So let me show the stress. Let me stress the importance of vascular property from the healthcare to medicine. So this is related to the mass screening. So because the pulse wave velocity, its increase comes first before average level of blood pressure increase. So or before hypertension diagnosis, and also atrial fibrillation and heart failure, and the ASCVD comes later. So this is the recent evidence of the CABI predict the predict the cardiovascular events in the outpatient at the cardiovascular high risk. So as shown here, prospective study, especially for the 9.5 or more high values, they predict the cardiovascular death with a heart rate, hazard ratio 3.8 and stroke 2.07. And also here, the heart failure with hospitalization is the highest risk predicted by the CABI. So stroke and the heart failure could be predicted by the increased pulse wave velocity. And also here, so CABI could predict. So as shown here, the CABI could be predict the new onset of hypertension. This is a model of the AI. So within the normotensive patient, the CABI and also the other metrics were measured. And then after the several years, we can predict the development of hypertension. So, and here, this is the AI model of the XG boost model could predict the hypertension. So as shown, sorry for this. Could you go back one slide? Yes. So as shown here, this is a degree of the predictors: age, BMI, and also the office blood pressure at the time of the CABI measurement. And also CABI was a predictor of the development of hypertension. Could you go next? Yes. So this shows the SHATS concept, the systemic hemodynamic atherothrombotic syndrome. It's a vicious cycle of the blood pressure variability and the vascular stiffness. So this vicious cycle could predict the risk for the development of the cardiovascular events and also small artery disease related organ damage, such as CKD or vascular dementia. Could you go next? So this shows our prospective study, cross-sectional study of our JHOP study. So vertical axis, horizontal axis is a blood pressure, home blood pressure variability, and vertical axis is a NT-proBNP. As shown here, the stiffness artery, the patient with stiffened artery exhibited the increased the NT-proBNP steeper than those with the low or BWB. So higher stiffness will accelerate the cardiac overload by increasing the blood pressure variability. Could you go next? And also here is the cardiovascular event. Vertical axis is cardiovascular events. As shown here, the higher PWV predict the higher risk according to the increase in the blood pressure variability. So vascular variability, its risk is accelerated by the patient with stiffened artery because of the power of pulse could not be absorbed by the aortic artery. Next, please. And also here, so lower PWV, higher PWV group, as shown here, the ARV, this is the highest the quartiles. So highest quartile of the ARV predict the, especially for in a patient with stiffened artery. So blood pressure variability is risk of the blood pressure variability is accelerated by the stiffened artery from the early phase. Next, please. So, this is a clinical implication of the why we measure the we need to measure the pulse wave velocity to we should identify the high risk patient. And also here we need the pathological threshold. So for example, CABI 8.0 high normal from it's a threshold between the normal and the borderline, and abnormal 9.0. And next, please. As shown here, this is almost the CABI 8, CABI 9 is almost around the BAPWV 1,800, and 8 CABI around 1,400. So this is a very similar to the pathological threshold of the BAPWV in Dr. Tomiyama's Babel study. So we need even the different measures. Ideally we need standardization, but the comparison is not so. Practically, we may have the two different measurement, CABI or BAPWV, but we need to evaluate the individual change of the CABI or BAPWV by the treatment. I think it's almost impossible to standardize. If we can standardize measure to be the consensus by the consensus, we can have the consensus statement to combine or transition to use the CABI or BAPWV. It should be the ideal. But if not, we can measure using each measure each index. We can identify to reduce both of these measurement by the strategy first, the reducing the blood pressure level and variability and other components, other risk factors to reduce the maximally measurement of maximally the vascular index. So thank you very much for your attention.
So can we go to the next? So is that the discussion? So any comments on the really nice expose of these associated variables that convince people that pulse wave velocity can be used in the clinic?
Is there anybody who have seen the patients with the reduction of PWV? Usually in the cardiac hypertrophy, it takes about 6 months to see the changes of the cardiac hypertrophy, and the carotid plaque also happens when you wait 6 months. You can see some changes of reduction of carotid plaque or thickness. But in case, is there anybody who have seen the reduction of PWV in your clinic? Jim, you have seen
independent of pressure, you mean, Jeong Bae? Independent of blood pressure?
Yeah, if you reduce blood pressure, you may see the reduction of cardiac hypertrophy in your clinic. But if you can find some reduction of PWV in our practice, maybe it is a very good useful tool to apply in clinic.
Yes, we recently performed a clinical trial in patients with masculine hypertension. Those patients had a normal office blood pressure, but elevated ambulatory blood pressure, and we compared the antihypertensive treatment versus placebo in improving target organ damage, including brachial ankle pulse wave velocity, and we found that the antihypertensive treatment can reduce brachial ankle pulse velocity, but we don't know if it is independent of blood pressure or not.
So we can identify the masked hypertension, masked uncontrolled hypertension by the increased the PWV. You mean? I agree. So,
Yeah.
but target is a reduction of the blood pressure levels throughout 24 hours. So uncontrolled hypertension could be identified by the CABI or BAPWV. So it's a screening to detect the high-risk patient with uncontrolled hypertension. I agree.
I remember some of the early studies when ACE inhibitors were around, the basic science studies that showed that these compounds seem to have some structural effect on the arterial wall. You know, I don't know how much of that is actually can be shown in patients, but there appeared to be some extracellular matrix modification with the ACE inhibitors, for example.
Yes. So blood pressure reduction is very powerful to improve the vascular stiffness than the different classes.
Yeah, but we need a parameter to show the structural stiffness and the change in structural stiffness.
Yes. So for PWV, the stiffness is contain the functional stiffness with by determined by the increase the RAS, the renin-angiotensin system activation, and also sympathetic tones, and also, or as you said, the structure stiffness should be different.
Maybe these terms should be used more to allow people to differentiate between the structural stiffness and the functional stiffness. Although it's not easy to understand, but the general population. But I think it's important to differentiate the two.
Does heavy reflect more structural than functional stiffness? Albert?
Sure, Kavi. Yeah, absolutely.
Theoretically.
Theoretically, yes, exactly. And so these parameters then relate to the arterial wall, the actual
Yeah, but
arterial
I
wall.
saw from literature, CAVI is still dependent on blood pressure, but to a lesser
Less.
extent.
Yes,
Well, Dr. Spronck, because we made a correction when he was here
Yeah.
to make sure that it's totally independent of blood pressure.
It's a big debate. There is a big debate.
So I think maybe we should move forward because it's getting a little bit on the, maybe people have to, they've got time to, so Yan, up to you.
Yeah.
Yes.
So, it's my great pleasure to join this presentation. So in the consensus paper, in the section on clinical perspectives of the PWV measurements, we discussed several criteria to justify routine clinical use of a biomarker. But specifically for the PWV measurements, firstly, we think that the reliability, reproducibility, and the feasibility in a standardized clinical setting of the PWV measurement should be demonstrated. And the second, the measurement should carry the ability to add additional risk prediction and, importantly, discrimination beyond conventional risk scores such as Framingham risk scores. And thirdly, the clinical indication of the measurement should be provided. And not only for risk prediction, but also the measurement should be used for treatment monitoring or be set as a therapeutic target. So previous studies on PWV measurement have addressed almost all, but most of these criteria, but not all, especially for interventional studies. We lack interventional studies on PWV measurements. Yeah. How can I proceed? Yeah, okay. So we have a lot of studies showing that the PWV measurements can independently predict risk and can improve the reclassification of risk. So we might apply the PWV measurements in risk stratification of patients and making clinical decisions. For example, we may reclassify patients with intermediate risk into a higher risk level based on the PWV measurement, and for whom the treatment might be initiated or the treatment should be intensified. In another way, the patient with intermediate risk might be reclassified into a lower risk level based on PWV measurement, for whom the treatment might be avoided. So the PWV measurement might be used for risk stratification of these patients, especially for those with intermediate risk, such as those with borderline hypertension or white coat hypertension or other uncertainty risk conditions. And if supported by future randomized clinical trials, we may apply the PWV measurements in guiding treatment for the prevention of cardiovascular events, including the decision making to initiate treatment and to monitor treatment effects. or to set a treatment targets based on the PWV measurement. And to promote the clinical application of PWV measurement, we need more research, including but not limited to the following aspects. First, we might need the more research on the comparisons between various PWV measurements, and to develop a new method to calculate the parameters to assess structural stiffness. As we have discussed, we have several parameters of PWV measurements, but it's unclear whether the predictive value would be different between these various PWV measurements, and what values can be added on top to each other. And for interventional research, we definitely need a parameter that can assess the structural, the change in structural stiffness. And second, we might need to develop our Asian-specific reference values for the PWV values. As we know that populations of different ethnicity or with different environmental background may be different in the risk factors of pulse velocity, and also in the strength of the associations of these risk factors with PWV. As shown in this table, we had found that in the elderly populations in Shanghai, China, and in Malmö, Sweden, both CFPWV increased with age, body mass index, mean arterial pressure, and heart rate and plasma glucose, but the strengths of these associations were different between populations. And certainly, we need to develop new devices and parameters for the PWV measurement. And nowadays, we can monitor 24-hour pulse velocity with non-invasive measurements. But we don't know what's the clinical value of this daytime, nighttime, or the 24-hour pulse velocity. So we need more research. And recently, we can also, it's possible to estimate pulse velocity with with the smart wearable devices, as shown in this figure. We recently have such watch that can estimate pulse velocity. So such device is very convenient and is now become available in Chinese markets. But the clinical value of such measurement is remain to be determined. And in addition to the PWV mean level, the variability of pulse rate velocity is also a very interesting topic for research. We recently published a paper, and we found that the variability of pulse rate velocity during the CFPWV measurement, the CV of CFPTT as pulse transit time, can predict mortality outcomes in Shanghai and the Malmö elderly populations, independent of other risk factors. And lastly, I think we need develop new strategies and new drugs to intervene arterial stiffness. You might know the Bart trial is the first to compare the arterial stiffness based strategy to conventional strategy to in preventing cardiovascular and renal events. However, in this trial, due to insufficient statistical power, PWV-driven treatments did not significantly improve survival. But the treatments, the PWV-based treatments strategy do reduce blood pressure, office and ambulatory blood pressure, and also PWV values. So I think such research should be carried out in future larger trials. And also for the clinical application of PWV measurements, we need more drugs, more new drugs. Recently, several drugs such as SGLT2 inhibitor and ARNI it was demonstrated to reduce pulse wave velocity. But we definitely need new drugs, new targets to intervene to improve arterial stiffness. So this is, I think we need to really to do more research on PWV measurements.
Thanks, Yen. Maybe we can combine this discussion session with the next one, because we need to conclude at some stage soon, I think.
Yes, okay.
Any comments on Yen's presentation?
Well, one question, okay? Thank you very much for a nice presentation, Yan. Could you explain how you can measure pulse velocity by wearable devices? I cannot catch well. So how you can measure pulse velocity by wearable device?
The procedure is very simple. You just the measurement is based on the collection of the ECG signals and the fold and the pulse signals in the finger.
The PPG.
Finger.
Yes. Yeah.
On the wrist. The PPG is signal on the wrist.
So the measurements were only for 30 seconds.
30 seconds. Oh.
Yeah. Then the pulse velocity is calculated.
Very short pulse transit time.
Yeah.
Very short.
Right.
Is it reliable?
Excuse me. Kario, thank you for beautiful presentation. So I also want to ask you on the pulse wave velocity for wearable by wearable device. So for PPT is usually is sometimes used for the cuffless blood pressure monitoring, and partly the pulse wave velocity. So it's a different way. Using the transit time is the arterial stiffness, and also for its functional change could be transferred to the blood pressure change. So for vascular property should be closely they determine the clinical implication of the structural stiffness and also functional stiffness. Functional stiffness could be transferred to the blood pressure variability. So before determining the especially for the wearables, the small artery remodeling, determined how can you how could you interpret the wearable device the pulse transit time to the stiffness property or blood pressure cuffless property?
I'm not very clear about the principles of the measurement of of the estimation of pulse velocity by wearable devices, by this kind of wearable device watch. But I think the estimation is not only based on the signal analysis, but also based on the big data analysis and the machine learning. So this kind of new estimation of pulse velocity is not only based on the signals analysis. Yeah.
What is the gold standard of the teaching data of the AI?
Yeah, it incorporated AI. So they did a validation study. So they compared the estimated pulse wave velocity by this watch with the standard methods with using the complier device. So they observed very small difference between the two measurements.
Thank you very much.
Any more questions? Any more comments? You know, it's so nice to see that publication of the pulse transit time variability, because I remember a discussion we had in Yen's laboratory. I said there's enough information in these measurements or in time that it should be possible to get some measurement of variability. And now we've seen that variability actually is predictive. It's amazing.
Yeah.
So
my short question is, I am very interested in PWV guided therapy. In your Spark study, you didn't see any improvement of PWV guided therapy, even you see the blood pressure reduction and the reduction of PWV. Why do you see the disparity between the reduction of PWV and the outcome data? PWV-driven treatment did not significantly improve the outcomes, the survivors.
Yeah.
But it reduced blood pressure and PWV. Usually, PWV reduction may reflect improvement outcomes, but there is some disparity in the reduction of PWV and the outcome improvement.
Yeah, the principal investigator of the Spark trial is Professor Stephen Lohong. I remember the multi-center study in European countries. Am I right, James?
Yeah,
Professor Sharman?
Yeah, I think that the issue on that question, Jeong Bae, is that the study was underpowered for the primary endpoints in the end.
Yeah,
I think that's why it didn't
I think the negative results is because of the small sample size. Very small number of events occurred in the trial.
That's correct.
Any more comments? Otherwise, we can go to the final discussion on vascular aging, early vascular aging. Is it real? PWV guided therapeutic approach.
No, the first question is how many people apply the idea of the early vascular aging in the clinic? The question is it really important, like the hypertension treatment or diabetes treatment in your clinic? Do you get some idea of early vascular aging in your clinic? I want some idea from the gym. Do you have the similar idea in your clinic?
I can only really comment, Jeong Bae, on I think the papers that I've read in the field, and when we see the opposite end of the spectrum from early vascular aging and the supranormal vascular function with the very low pulse wave velocity associated with extremely healthy lifestyles. And I think we heard Stéphane Laurent's name mentioned earlier, and certainly he and colleagues in France have led the field in understanding this area. And they put forward the concept of early vascular aging very convincingly, in that the aorta itself becomes a reservoir for the cumulative burden of risk factors. And I'm convinced that it's real. And I guess the question, Jeong Bae, is it something that you see above and beyond, for example, normal blood pressure? To what extent would you see a higher pulse wave velocity in the setting of someone with normal or low blood pressure? And I'm not sure to the extent the prevalence of such a finding. I'd be very interested in others' perspective here. But I think one of the sort of several things that have touched on in the conversation, and Jan's really nice presentation, and the questions that you raise, including the new agents to actually target structural stiffness, because once you intervene to lower blood pressure with conventional antihypertensive agents, what choice have you got next to intervene on the target of the aorta or the stiffened artery, because there aren't any agents available. However, lifestyle is probably the most effective intervention, including lower salt and more exercise. These things have really shown to improve an early vascular aging phenotype. So I've probably thrown more questions back to the panel with that answer, but thank you, Jeong Bae.
Taking just one pill is much easier to do exercise or reduce your body weight.
So, say again, Jeong Bae, easier?
Taking just one pill of medication is much easier to reduce your body weight.
It is indeed.
Almost impossible.
It is indeed. I agree.
I suppose these things can be seen, obviously in the context of broad knowledge, but also in the context of future approaches to precision medicine, I suppose, in terms of targeted, data. Now everybody will have their data profile, in association with their bank account. There will be the blockchain that will have people's medical profiles and so on. And so eventually it's going to be like that. So again, as we were saying, in terms of risk stratification, if you're borderline, which way do you go? Now, all these things will contribute, and aspects of early vascular aging, if you are of a certain phenotype, you go in the other risk. And so, prescribed treatment will be made accordingly, as I understand. So a PWV guided therapeutic approach may be one of those, maybe one of these elements.
May I ask all of you? I have a small question. Early vascular aging means some pathophysiological condition in longitudinal standing. And on the other hand, early vascular age, it means just a cross-sectional assessment. How do you think about that? It's the same ones, or we have to distinguish separately? Do you have any comment about the vascular aging and early vascular age? Do you have any comment about that?
So let me see if I'm understanding it. The aging, it's like stiffening. It's an active process.
Yes.
Whereas early vascular age is a definite. At that point, you are older than your arteries are older than your chronological age. So I think, Bart, what do you think?
Yeah, absolutely. I was making the same analogy in my head, indeed. So, one of, in my opinion, one of them is the process, and one of them is the current state. Same for stiffness. We have stiffening and stiffness as a number. Yeah, and So which one is more important? So I guess one is the change over time in the other.
So just on that, so to get the dynamic process, you need dynamic data. You need time-dependent data. You need, slopes. You need sensitivities. You need dynamic data, and that's interesting. If one can look at, rate of change of something, for example, with exercise, what's the pressure dependency when you have an intervention of a person? That's sensitivity. The arteries have a sensitivity to an intervention. If one could obtain that type of dynamic change, for example, some work we did with cuffless blood pressure, where you have different interventions, the same change in blood pressure causes different changes in transit times. Exercise is different to a cold pressor test. How come? So, and different people have different sensitivities to these responses. So maybe a combination of, dynamic sensitivity to response with these concepts of early vascular aging. What is it that is causing the aging? And is it something that could be used in terms of these parameters for input to risk, for example? So I think the future is rosy, is fantastic for, intellectual pursuits. The reality is that we still do not have clinical measurements of pulse wave velocity. So, in most places, except in places where there is reimbursement. So maybe, Jeong Bae, do you want to make any concluding remarks?
Yeah, thank you very much to have this wonderful discussion, and your contribution on this expert consensus paper really improves the clinical utility of PW measurement in clinic. Hope to see you later to discuss more on the papers on this webinar. Thank you very much for your support. Thank you.
And thanks to Jeong Bae, and thanks to Kaga for organizing it. Thanks very much.